Yeah, Dr. Ivy, well, really well done. It's quite a tricky case with a few social situations. You opened very nicely and very quickly. You didn't waste a lot of time. The patient said, "Oh, this is happening again," and it's happening a lot of times. I would be interested. Did they need to go to A&E ever? Because that would change management. Because sometimes in these situations they need secondary support when they're not having exacerbation. I would also be interested, how much can they walk? What is their sort of baseline? And we know their usual peak flow is 580, but I don't know, does this patient have a peak flow right now? Could they help us perhaps do something that would be helpful? I also like that you explored red flags early on. That was very nice. You did ask about bowels. I would be interested, maybe the patient has been coughing up blood. But the rest of the things you asked were very relevant as well. You explored medication, and that was really good. And I think that gave us an understanding how this patient sort of does not have access to medication, and they're not using their medication appropriately. And also, I'm not sure if I just missed it, but how often are they using their inhaler? Have they just needed it, for the past 2 days? Have they been using it 20 times? Because that would definitely change things, and I'll be interested to see how they've improved, if that's improved or anything. You said something really nice, and I saw the patient smiled as you said it. You said, we'll see how we can sort it out. I think that's a really nice statement, and we'll see how we can help you. We'll see how we'll take things further. I think these sort of showing joint care, showing it's a we, not a I versus you. I think that's really, really nice. In terms of the homelessness, I understood that the patient couldn't pay the rent, but I would be interested, what led to that. Sometimes people get addiction, and that can lead to these situations. What exactly brought the patient to this situation? How did they become homeless, and sort of how long have they been homeless for? Is this an ongoing situation? And in this case, I don't think the patient knew what they are sort of entitled to in terms of like benefits, social care. And going to management, you moved on very quickly. You didn't waste time, and you picked up on the smoking. But unfortunately, we didn't get time to discuss that in the management. But I do know that you brought the patient in, and you explained what you'll do. You explained the medication, and you explained, the steroids as well. That was mentioned. So you sort of said what you're going to do, which was nice as well. In terms of more of the homelessness, I liked how you brought it as options. So there's charities, there's social care as well. But also maybe we can dispense the medication altogether, maybe for 3 months, so they won't need to keep coming to the pharmacy. So that's a really good way. And also for continuity of care, I'm glad they have a phone now. Is this their usual number? Are they a patient that perhaps they need to use the GP address to register as a patient? So not to register, but to so they register their address as the practice address, so that's how they can receive letters and follow up, because this patient is a vulnerable patient essentially, that is struggling. I also like that you brought everything together as well quite nicely, and everything was presented as options. You asked about mood. I think that these were all things that I wrote loads of ticks. So really well done. The patient did say they're stressed. They drink to forget things, and it's quite stressful. You did ask about mood, and just a bit more, how are they coping with that stress? What are they really doing? Just that extra bit of curiosity. I think that would have been rounded up your points quite well. But well done.
So thank you for the feedback to our guest examiner today. There is a lot in this case that we've done. This case is heavy on the PSO. And sometimes long-term cases come like that. We see it like, it's a simple case of COPD. But sometimes the complexity is that PSO or the social life of the patient. So we've got to be eliciting that history so that we can manage this patient robustly. Because as we can see, the homelessness in this case led to the patient being more stressed, and then the patient has picked up smoking again. And maybe that's why the COPD is also worse at having exacerbation. The other thing here as well is that patient is not compliant on medication, access to healthcare is a problem. I think that's a learning point here. So action plan, anybody listening, what are the things that needs to be done for homeless patients? Because this homeless aspect of care comes up in different ways. I've seen it in GP practice, I've seen it in out of hours where patients are homeless. So the tactics or the advice, can they register with your practice? as a temporary address. That way they can then go and apply for benefits or job center, but your GP practice is their temporary address until they have a home. Social charities that can support patients. So there is books, there is shelter. What's the local one in your area? The local one in your area is called 13. So 13 groups. So if I'm talking to patients locally, I can then mention that there is a local charity that works with the council to build houses and support patients to get houses. Would you be happy to apply for housing through the group? And then I explain, or would you want to go to the local council? So you give patient options, but sometimes bring that option down to what's done in your area, because they want to see that little unique things that we do in clinical practice. And Dr. Rim, who gave the feedback, gave something very nicely, asking the patient for SpO2, so oximeter. That's something I do. I ask patients. And for peak flow, since the COVID pandemic, patient access to devices change with the COVID pandemic. So in your data gathering, think, does this patient have a BP monitor? Do they have oximeter? So relevant to the case, if I'm seeing a case of hypertension, I always ask if they have a BP monitor at home. For £50, patients can invest and buy that device because it's an investment in their health. So that's my way of explaining to patients why they should. So this is an investment in your health. It helps you check your BP on a regular basis. That way you know when to call for help if the BP is not well controlled with your blood pressure. Would you be happy to buy this device? That's my negotiation if it's a new hypertension. So in the follow-up, I then ask them if they have that device. But in this case, where it's exacerbation of COPD, if you ask the patient for their SpO2 peak flow, patient can actually say, yes, I've checked it. Here is my number. And then you can then compare to the patient, to the doctor's notes. So if you're just reading the doctor's notes and you're reading it there, everybody sees it. Reading it to the patient is not going to make a difference. That's why I said, doctor, you have my notes there. That if it's there, then it's there. Because you're reading it back to the patient may not remember. But the point of you using that doctor's note is because you want to compare it to whatever baseline or numbers the patient is giving you. And this tactic works if it's asthma or if you are speaking to a healthcare professional like a paramedic or a care home. So anytime I'm doing out of hours and I'm speaking to a care home, I ask them, are you able to check this patient's vital signs? And some care homes actually do it before they call you as a doctor, and they will give you the vital signs right there on the phone. If it's a paramedic will read it out for you, and you kind of ask them, did you do an ECG as well? And the paramedic will say, yes, it says sinus reading, because with doing that, you're finding out the baseline, getting their clinical opinion, and also showing respect to the work that other people do. So if you ask that, the patient would have then giving numbers and say, okay, this is what my peak flow is, and that changes your management. Because if you're asking me for peak flow, SpO2, and I'm telling you that my SpO2 is 81, and the last one you saw right there was below normal or within normal levels, which is not the patient's baseline, you know that this is not a case to manage by medication, but that's simple. COPD now needs to be going into the emergency department. So you can see why asking for patient numbers makes a difference in your clinical management. Throughout our session today, I'm picking up that we are not really using our CFAB questions to the fullest. So tell me, how have your COPD been before? Patient then gives you that history. Well, I've had a lot of exacerbation, because the frequency of exacerbation is very important in the management of COPD, changes a lot of things and gives you that holistic picture, especially when the patient is now using a lot of steroids. So I would have said, oh, doctor, I had about 5-6 episodes last year. I always went to the emergency department. You are not picking up that there is steroid burden in this case, and your management then needs to cover talking about osteoporosis risk assessment in that case. So your CFAM question really helps. You can see how it leads from checking for control of symptoms, leading to frequency of exacerbation, and then thinking about steroid burden and osteoporosis risk assessment. So control as well. When you get symptoms, when your symptoms flare up, what do you usually do? Oh, doctor, this is the reason why I'm calling. We want antibiotics and steroid, because that's what the patient usually does. If you're homeless and you don't have any GP, where do you get the medications from? I always go to the emergency or to the walk-in, which I gave, and just like the feedback our guest GP has given, show that curiosity. Because if you're just asking the basic question and moving on, you are not getting a lot of things. So access to healthcare is important in this case. But how have the patient been managing with his lack of access? And you are eliciting that pattern of health-seeking behavior. Either he's going to the wrong place, or he's not going for follow-up, or you're identifying challenges that need to be addressed. So the frequency of exacerbation is important, because you ask how many times per year. If you remember your GSF guideline, on how to identify patients who are declining with COPD and when to initiate conversation for DNA-CPR or end-of-life care. It talks about exacerbation more than 3 per year. We need to be talking to the patient because either it's uncontrolled and you're managing that, or this patient is approaching end-stage COPD. Does this patient need oxygen? Do you need to be talking about resource documents and planning the future of this patient? And this is why that robust data gathering matters. It's not just about the simple questions of where is the pain, shortness of breath, hemoptysis. Good questions, because those are your red flags. But how do you go from an amber patient or a fail to a pass? But we are hoping for a pass to a clear fail in our cases. How is it being treated? The symptoms the patient is having right now, is it similar to previous exacerbations? Because this is your way of checking alternative diagnosis. What if this particular chest pain, COPD symptoms, so breathlessness, coughing, what if it's right heart failure as a complication of COPD? What if it's cancer? So you can ask patient, is this breathlessness or your symptoms, is it similar to previous episodes? That's a way of testing patient's perception of the illness, rather than saying, do you think this is COPD or do you think this is the same? So different ways that you can check these things. But also the severity and the admission is important. Is your symptoms today as bad as previous episodes? Open questions, or a bit close, yes or no. Or previous episodes, have you been admitted to the hospital 4 days? And the patient is saying, yes, my symptoms go really fast. I always end up in an ambulance. I always get ITU. You know that, okay, this is not just a case, you're trying to be bringing this patient in. It's not just a case for medication, go away. You probably need to be on deck with this patient and think, is this case bad enough to be going back into the hospital, knowing that this patient decompensates really fast? And this is just the extra bit we ask in our data gathering. The PSO, we've talked about this. This case is heavy on the PSO. The homelessness and lack of access to healthcare was a very big factor in this case that also needed to be addressed. But we should also be thinking about triggers. So in this case, it's smoking. But what if this man is not smoking? Some people explore, is there anybody around you who smokes? Because that can be a trigger. If it's working, your symptoms worse at work, because you want to check, is this occupational related, occupational asthma, are there dust and chemicals that's triggering this patient exacerbation? And that's important because when you start classifying the type of COPD, it makes a difference in how you communicate the causes of the COPD to the patient. But we talked now about the classification. So alternative diagnosis, we know, because it can be poor medication compliance, or occupational infection, ask your red flags, very important in all your cases. But when it now comes to explaining the diagnosis to the patient, and here is a really good technique I learned. There are certain conditions where you've got to classify. So COPD, is it uncontrolled? Is it effective exacerbation or non-effective? Or what's the other one? Is it end-stage COPD? If it's asthma, is it uncontrolled, effective, occupational asthma? So see the difference in how you explain this diagnosis to the patient. So you classify the condition because it changes how you communicate the diagnosis to the patient. So for example, if I'm using a diagnosis, for example, so I may say, John, I think what you have is called depression. And because you've lost your wife and you've been struggling since her passing, such that you are staying at home, you're not eating and drinking, we'll actually call this reactive depression because you've recent bereavement where you've lost your wife. Now, I know I said reactive depression there, but I can actually explain this without even using reactive depression, just by talking of the depression and relating it to the triggers. But if it's endogenous depression, I say something like, John, I think what you're going through is depression. And in your case, you are feeling depressed. Where do we, I'm sorry, I'll say that again. So, John, based on what you've mentioned, I think what you're going through is depression. And based on what you said, there is no trigger or particular reason why you feel this way. But it's usually common in if you have a family member with depression and your symptoms have gone on during the winter. So you start using things in the patient history to explain why this is endogenous depression, even without me saying the word endogenous. And that's the tactic we should be using in classifying certain long-term conditions where we know that there are different types of that condition. So, John, based on what you've mentioned, I think what you have is an exacerbation of COPD. And because you're smoking and you've been homeless, you've been out on the streets in A, B, and C, there is a chance that this is an infective exacerbation of COPD. So your symptoms are caused by an infection causing a flare-up. So at the moment, I would like to talk to you about medications to do A, B, and C, X, Y, and Z, and then you move on to your management. Another thing that sometimes add is the severity. Going back to depression again, depression can be mild, moderate, or severe. Why is this important to classify that? So you're talking to the patient, but you're also showing the examiner that you are classifying your diagnosis. If a patient is coming to you and saying, I'm feeling depressed, but you do your data gathering, and in that case, patient goes to work, patient is eating and drinking, they are still having a social life. So you're picking up a picture of mild depression. But yet the patient is asking you for medication and a referral to the mental health crisis team. But we know that evidence-based practice says that we should first offer counseling. So while you want to address the patient's agenda, you have to still explain why you are not jumping straight to medication or to the mental health referral, and why you are offering counseling, by then saying, based on what you've talked about. So I talk about the diagnosis, and then I tell the patient, based on what we've talked about, it appears that your symptoms are mild. And at the moment, what we tend to do to manage mild depression is refer you to counseling. Is this something you'll be happy to try? And if you go for counseling for 6 weeks, 8 weeks, whatever you want to say, and if that doesn't work, we then have the options to try medication and refer you to the mental health team for further follow-up. What do you think about this? You are now negotiating with the patient just by explaining the classification, that it's due to certain triggers, explaining that it's mild, and this is the reason why you're offering counseling, and addressing those triggers for the depression, rather than giving the patient medication as your first line and referring to mental health. So this is the tactic we tend to use in cases like COPD, asthma, depression, in fact, inflammatory bowel disease, where you know there is a flare-up, or it can become complicated with perforation. So always think about cases like this to say, oh, do I need to be classifying my diagnosis? Do I need to be mentioning severity? Because that severity matters in what you offer the patient. But in cases like COPD, you've got to talk about the immediate treatment. So this man needs antibiotics and steroids, like Dr. IB rightly mentioned, the doses and side effects. Always remember the tactics for explaining medication. State the dose, state how to take it, expected side effects, how to manage it, and when to seek help. So you explain that robustly. But in COPD, patients need to come back within 72 hours for a follow-up. So if the patient is very unwell and you need to be seeing the patient now or sending to hospital, that's a different management. But if patient needs, you're going to send the medication, then patient needs to come in within 3 days, 72 hours for a follow-up. Because 9CKS says that when you do that, when you see the patient in clinic, you check that symptom is controlled, check medication compliance. If symptom is not controlled, think about doing a sputum test, a chest x-ray, and changing the antibiotics of the patient. And this is how you tweak your case, making it relevant to the patient, but also following evidence-based medicine. Same thing with asthma. Patient has an acute exacerbation. When do you want to see the patient for an immediate follow-up? And then you talk about the follow-up afterwards, where they then see the nurse in 4 to 6 weeks to make sure that their symptoms are controlled, medications are working fine, check a new baseline, update their asthma action plan. And then if it's the time of the year, patients then get their annual flu vaccine and the one-off pneumococcal. And if it's age appropriate, so depending on the age of the patient, are they due for shingles vaccine? So you talk about that long-term follow-up the patient needs and the long-term care. Long-term care would be the register coming in for the annual reviews, like we've mentioned earlier on, telling them that they're on the register, and they'll be getting an invite for annual reviews every 6 to 12 months. But if the patient has an unrealistic belief or expectation, so here in this case, this patient smokes, and patient says, oh, doctor, I know, it's a cigarette, I've gone back to smoking. You address that because you want to challenge that and use that to encourage the patient. So you mentioned earlier that you are aware that smoking causes COPD, but in this case, you can see that the smoking has actually brought on a worse symptom of COPD. What do you think about us talking about quitting smoking? There is support, there is A, B, and C, as nicely as Dr. IB has done it today. Same way, if you see a patient who has cancer or a suspected cancer, you can use that part of the history to say, because we are worried about cancer, let's make sure that we check the cancer out, you do a referral, A, B, and C. But when you come out of hospital after your referral, let's talk about quit smoking, because while we want that there is no cancer, your symptoms are better, let's talk about ways to prevent the cancer from coming, and that's to stop smoking. So you use that information to then enhance your point. why patients should smoke. Because in the UK, they hear it all the time. Every appointment, the doctor, the nurse, the paramedic, hospital, in and out, they go for eye checkup. Everybody tells them stop smoking. So some patients might come in very irritated when you want to talk about smoking. And I actually do a role play where I tell the patient, doctor, everybody tells me about smoking. I don't want to hear it anymore. Just give me my medication and go. How do you then tweak your conversation to that kind of challenge from a patient? So I then say something like, and I get this a lot in clinic, even yesterday in out of hours, I say something like, I know you're fed up with everyone talking to you about smoking, but it's important that we are controlling your COPD and we support you to quit smoking. Now, it might seem tiring talking about this, but I wonder if you would be happy to speak to me about quitting smoking. We can talk about things that you've done that didn't work. We can talk about things that make you want to smoke. And then we can talk about a referral to the smoking clinic if that is needed. Would you be happy booking an appointment with me in clinic so that we can then talk about this in more details? So what I have done there is I have acknowledged that it's a tiring conversation because some patients actually feel that they are being nagged by the NHS to quit smoking. But what I've done there is I've acknowledge that yes, you've had this conversation, but I would still like to talk about it again. I take ownership of the case and then I relate it to what the patient is going through, whether it's the cancer scare or the COPD, or say let's talk about it so that we don't keep having this problem you keep having. So you can always tweak that conversation to challenge any unrealistic belief that a patient brings in. So you can always go in a bit more your data gadget to say, have you tried quit smoking? Would you need some help with this? So that in your clinical management, you can then say, I know earlier on you mentioned you didn't want to quit smoking and you don't need any help. But I wonder if you'd be happy to talk to me a bit more about how you feel about your smoking. Because now that the COPD is getting worse, it's important that we are controlling the COPD, but we're also preventing the COPD from coming back. And that's by addressing the smoking and ways that we can support. So you can see how I changed the clinical management by using what the patient have told me in the explanation and then using that in my clinical management. And of course, we've talked about that osteoporosis risk statement because by checking that exacerbation and how much steroids the patient is using, you've got to be thinking, oh, do I need to be doing this osteoporosis risk assessment with the patient? If the patient is declining, your GSF bullet points on identifying a declining patient, where it says, if this patient passes in 1 year, would you be surprised? Yes or no. If it's a no, you will not be surprised. That's already an idea to start triggering the conversation about DNA CPR. So if I'm having this case and it sounds like I'm already on oxygen and I'm having 7 exacerbations in a year, you've got to be thinking either it's not controlled, medication compliance, or end stage, do I need to be having full conversation with this patient? And in situations like this with point 4, you learn when do you talk about this and when do you benchmark that conversation for another appointment. So what I would tend to say is, there are other things I want to talk to you about. Because you've been using a lot of steroids to control the COPD last year, I would like to do some medical calculation to check how much the steroid is affecting your bones, and I would like to talk to you about that in clinic. Would you be happy to book an appointment with me so that we can talk a bit more about how much the steroids can affect your bone, and we can talk about ways to prevent this? Yes, doctor, I'm fine. Patients just want to say. Then I can follow up with the second point, future care planning. When I see you in clinic, there are some documents I would like to talk about as well. It's about your health, the ways we can take care of you in the future, and a special document called a do not resuscitate, so that we are documenting how you would like us to care for you in the future. So when we book an appointment, I will speak to you about all of this. But in the meantime, then I move on to another of my points. So, but you've got to use that with relevance to the case, because if this is a new diagnosis or just uncontrolled and discussing future care planning is not relevant, then you don't need to do that. But what we try to get you to do or think is the holistic management of COPD, so that in the exams, the examiner know that, oh, you talked about this, you talked about the early decline of a patient. Is the patient eligible or reaching the point for end stage COPD and long-term oxygen? So action plan, if you're listening to this anywhere, think, if I were having a case of COPD and the patient needs to be on long-term oxygen, what do I do? You need to refer back to respiratory teams for pulmonary rehab and for pulmonary assessment, including spirometry. And they are the ones that then decide or give that feedback whether the patient needs long-term oxygen, and then that's then put in place for the patient. But how do you then communicate that referral to the patient? So action plan, homework to do if you're listening to this. Now, patients with COPD, talking about long-term management, many of them with oxygen travel. They travel by car, they travel by air, they go places. If you are having a case of COPD and you need to discuss long-term oxygen and patient travels, how do you have that conversation with the patient? What questions do you ask? You ask about insurance. Are they having cylinder or concentrator? Do they, who's traveling with them? Have they made plans to get oxygen in the location? So there are a whole lot of questions to ask. There is a website online that talks about living with COPD and long-term oxygen and how patients can travel. So I'll share that in the group and in template, but please read on this because the advice you give differs based on whether they're going by car or by air, and then the activities they are going to do when they arrive, because their oxygen is flammable. If they're going camping and they're going to light a camping fire, that's different from if they're just going to a spa and they're just chilled by the poolside and they're not doing anything that can be flammable. So the advice you give will be tweaked to the COPD, to the oxygen, to the travel plans, and every other thing that the patient is doing. So this is only an aspect of long-term care of COPD, but you can see that COPD can present in different ways. So the journey of COPD from diagnosis to long-term oxygen use and palliative, the advice and the management of cases differ. So what we try and do is get you to think about that life and living with COPD and how you manage cases going forward.